Next speaker is Dr. Awal Zaki. She is a specialist immunologist in Regional Lab Dammam. She is going to present two abstracts.
Assalamu alaikum. I would like to thank the organizing committee for accepting these abstracts. These abstracts is part of my PhD work. I did my PhD at the University of Manchester at the Arthritis Research UK. The project was part of a bigger project. The team was interested in looking at the cardiovascular disease association with autoimmune diseases, especially with SLE and rheumatoid arthritis, trying to look at the risk factors for having cardiovascular diseases in these two conditions. Can I have my slides? Yeah, first talk will be about predictors of overall and cardiovascular disease mortality in patients with early inflammatory polyarthritis, the lipid paradox, results from NOIR. Rheumatoid arthritis is a chronic inflammatory disease. It affects 0.5 to 1% of the general population. The majority of mortality studies indicated excess mortality rate in rheumatoid arthritis compared to the general population. Many of these studies highlighted excess cardiovascular disease mortality. There are several risk factors for having cardiovascular diseases in general population, as you all know, mainly age, male gender, dyslipidemia, diabetes, obesity, smoking, hypertension, and family history of cardiovascular diseases. The association between lipids and outcome in rheumatoid arthritis is complex. There was a report in 2011 that indicated a paradoxical association between lipid profile and cardiovascular disease outcome in rheumatoid arthritis. So we aim to replicate that study in UK. So the aim of this study was to examine the impact of lipids on all-cause mortality and cardiovascular disease mortality in patients with early inflammatory polyarthritis. This study was performed at the University of Manchester. We used the NOIR cohort. NOIR is the Norfolk Arthritis Registry. 1,266 patients were included in this study. NOIR include patients with early inflammatory arthritis, adults aged more than 16 with 2 or more swollen joints. The swollen joints should last more than 4 weeks. At the assessment, there will be an interview performed by a research nurse. The research nurse will perform detailed interview with the patients, asking about symptoms. A blood sample will be withdrawn, and joint examination and assessment will be performed. Clinical assessment include DAS score, HAQ score. Autoantibody profile will be performed for these patients in addition to lipid profile. Our results, demographics of this cohort, the median age was 58 years. As in all cohorts, 2/3 of patients were females with median duration symptoms of 8 months. 40% of this cohort was rheumatoid factor positive, and a quarter of them were ACPA positive, and 40% were either fulfilled the ACR criteria for rheumatoid arthritis. Lipid profile, the total cholesterol was 5. There were around 17% of patients who are having high total cholesterol, and around 50% having any dyslipidemia. Follow-up of patients until December 2010, the median follow-up time was 5 years. During this time, 100 patients died. Quarter of the patients died due to cardiovascular disease death, and the other patients died due to other causes. We did multivariable analysis for predictors of overall mortality. We find that HAQ score was associated with increased risk of all-cause mortality. As opposite to in general population, surprisingly, we find that total cholesterol was associated with decreased risk of mortality. And this was statistically significant. Similarly, for cardiovascular disease mortality, we find that total cholesterol was associated with around 50% decreased hazard rate of having cardiovascular disease mortality. In conclusion, in patients with inflammatory polyarthritis, lower lipids at baseline were associated with increased all-cause mortality and cardiovascular disease death. Lower cholesterol levels may reflect a higher inflammatory burden, but may also be associated with lipid subsets which are more prone to oxidation. Clinical impact, the paradoxical effect of lipids on the survival highlight the importance of monitoring the risk for cardiovascular disease in patients with chronic inflammatory conditions, especially in patients with chronic active disease flares. Serial measurements of lipid profile in patients with active inflammatory condition is mandatory in risk assessment. Lipid profile is affected by the inflammatory activity. Thus, risk assessment in patients with chronic inflammatory conditions is different from individuals without inflammatory conditions. This was the first presentation. Can I move to the next one? Yeah.
Any question about this?
Sorry?
If they have any question.
Any question? Sorry, I can't hear.
Excellent talk. Ibrahim Maghlouth, College of Medicine في الملك خالد الجامعي رياض.
Thank you.
So there are a couple of points. The first part is it's very difficult to incorporate lipid profile when you have when you have a paradoxical presentation. So for a clinician, they would not start any preventive treatment without having elevated lipid profile. And in your data, you're showing that the lipid profile goes actually down, correlated with the possibility of inflammation. So I think we probably still in need for a prediction model that take into account the inflammatory status as well as the underlying rheumatological condition, and I believe that there is ongoing validation tools for a predictive risk factor for lipid profile.
Totally agree with you, because this was like an exploratory study at the beginning, and we found this interesting data came in association with the same findings from, I think that study from Mayo Clinic.
Yeah, the second question that I have for your blood workup, did you look at the initial presentation only, or you did look over time? And if you did look over time, did you have repeated measure analysis?
These all at baseline measurements. Patients are continued to follow up at annually basis until 5 years, and then they were followed up at year 7 and year 10. Of course, any patients who satisfied other connective tissue disease will be excluded, but patients who fulfill rheumatoid arthritis or who have this polyarthritis, inflammatory polyarthritis, will stay in the registry, but all assessments were done at baseline.
Perfect. Thank you.
Thank you.
So I have one question. So most of these patients, they are having inflammatory arthritis, right?
40% of them fulfill the ACR criteria at baseline assessment.
Okay.
And they will be continued to follow up, even if they are rheumatoid arthritis.
Okay, right. Thank you.
Because I think after 5 years, another 50% they will fulfill. From the follow-up of this cohort, they find that after 5 years of these patients with early inflammatory polyarthritis, 50% of them, they fulfill the ACR criteria.
Okay, so you can proceed for the next.
No, not this one. No, not this one. Yes, this is the one. The other study is done on patients with SLE. We looked at the oxidant stress and associated with subclinical atherosclerosis in patients with SLE. Until 1976, Urwitz et al., they introduced the bimodal mortality in systemic lupus erythematosus, where they stated that patients with SLE they die early at the disease, either due to disease complication in the first 5 years, and the other half of patients, they die early due to cardiovascular disease. Premature atherosclerosis is a major cause of morbidity and mortality in patients with SLE. They find that women with SLE have up to 50-fold increase of risk of having myocardial infarction. There is also increased risk of having subclinical atherosclerosis as measured as the presence of a plaque on carotid ultrasound. The objective of this study was to look at the effect of oxidant stress in the prediction of future cardiovascular disease. So we hypothesized that patients with SLE have increased level of oxidant stress, and this oxidant stress is contributed to premature atherosclerosis. The aim of this study to compare lipid subtypes and markers of oxidant stress in SLE patients and healthy controls, and also to determine the association between the above markers and subclinical atherosclerosis. Method, this is a cross-sectional study. 168 women with SLE who fulfill the ACR criteria were included as cases. 56 matched healthy controls were included. Subclinical atherosclerosis was assessed using B-mode Doppler ultrasound of the carotid artery to assess the carotid artery intima medial thickness and identify plaque. Oxidized LDL and lipoprotein little a were measured by immunoassays. Results, demographic data of this cohort. The mean age for this cohort was 47 for the control and 52 for patients. Total cholesterol was slightly lower and significantly lower in SLE patients. There is increased oxidized LDL level in SLE patient compared to control. Our results showed that with regards to carotid IMT, there was no significant difference between patients and control. When we look at overall cohort, there is no difference with regards to IMT or plaque prevalence. But when we stratified our patients by age, patients who were less than 55 years have higher prevalence of plaque compared to healthy control. Then we looked at correlation between oxidized LDL and subclinical atherosclerosis. We find a positive association between oxidized LDL and carotid IMT in both SLE and healthy controls. Oxidized LDL was positively correlated with carotid plaque in SLE only, and lipoprotein little a was significantly associated with carotid plaque and weakly with carotid IMT in SLE patients only. Among the traditional risk factors, increased age, systolic blood pressure, total cholesterol, and LDL were significantly associated with carotid IMT in SLE patients at univariable analysis. And only age was independently associated with carotid IMT and healthy control. In conclusion, higher prevalence of carotid plaque was reported in SLE patients aged less than 55 compared to healthy controls, and this comes in accordance with other studies. There is evidence of increased oxidant stress in patients with SLE, and this was associated with subclinical atherosclerosis in patients with SLE. Control of inflammatory may reduce oxidant stress and subsequently reduce the development of atherosclerosis in this population. Thank you.
Thank you, Dr. Awal, for
Thank you.
these very important topics in rheumatology.
Thank you.
Yeah, and any question about this abstract? Yes, Doctor?
Because it is by design. By design, we intend to have female only who are SLE, because anyway, males with SLE is less. It's 9 to 1, the prevalence. So by design, actually the design of this study was performed before I joined the university. So I think by design, they intended to have it females only.